Obstetrics is unpredictable. It is where joy and crisis can coexist. Now, I invite the chairs for the session, Dr. Shaji PG, Dr. Sri Kumar Sharma, Dr. Anu Janardhanan. Postdural puncture headache, common, distressing, yet preventable and manageable with the right evidence-based approach. I invite Dr. Priyanka Pavitran, consultant from Aster MIMS Core Code and author to numerous publications and journals, to the stage.
So at the outset, I'd like to thank the organizing team for this great opportunity. And today, we'll be discussing on the evidence-based guidelines for the management of postdural puncture headache. So this condition was first described by Sir August Baer way back in 1898 when he described the symptoms he developed after he was given a subarachnoid block. Now, centuries later, despite advances in technique and equipment, PDPH still remains a significant source of patient morbidity. So PDPH is frequently associated with neuraxial blocks, but it can occur after any types of lumbar punctures. And among anesthetic cases, PDPH is most prevalent in the obstetric population. The incidence varies between 2 to 40%, and it depends on several factors, including patient and procedure related. So this evidence-based guidelines was published in 2023 and was put forward by a multi-society working group where they provided clear-cut recommendations for improving the patient management. So we start with the diagnosis of PDPH. So according to the updated definition by the IHS in 2018, it is defined as a headache attributed to low CSF pressure occurring within 5 days of an LP. It is caused by CSF leakage and is accompanied by neck stiffness and hearing symptoms. It often remits spontaneously within 2 weeks or after sealing with a blood patch. But there are several flaws with this updated definition, with the omission of postural component being the most controversial one. So in 2021, ASA put forward a statement which said that diagnosis of PDPH is based on clinical presentation, history, and physical examination. Typically, it does not exhibit any clinical features of infection or neurological deficits, and in a few atypical patients may not have the postural association. So it is recommended that PDPH should be suspected if a headache or neurological symptoms, which may be relieved when lying flat, occurs within 5 days of a neuraxial procedure. And a word of caution here, anytime you are making a diagnosis of PDPH, we should always consider the differential diagnosis according to the clinical scenario. Now, is there a role for imaging? Imaging is not needed for routine assessment of patients with typical symptoms because most of those patients do not have any specific findings on imaging. And a minority of patients may show signs of intracranial hypotension, which can be summarized under the mnemonic SEEPS. So when do we consider imaging? Imaging is indicated when the patient has any red flag signs, including the focal neurologic deficits, visual changes, cranial nerve palsies, or altered consciousness, or if there is an atypical presentation with the absence of postural association or onset beyond 5 days after LP, or if you suspect infections or patient develops seizures. So with that, we move on to consider the factors which increase the risk of developing PDPH. So a younger age, female sex, and a history of headache increases the risk of developing PDPH, whereas BMI, depression, and pushing during the second stage of labor does not increase in the other risk. And interestingly, smoking provides a protective effect. And when moving on to the procedural characteristics, the needle design is one of the most implicated ones, and it is the non-cutting design needles reduce the risk of developing PDPH, and it is recommended that non-cutting spinal needles should be used in all cases of lumbar punctures. And when using cutting needle designs, the narrower gauges make a difference, whereas there is no difference of using a narrower gauge when in cases of non-cutting needles. So there is a positive association between the increased number of attempts and the risk of developing the PDPH. A higher level of operator experience reduces the incidence. When you are using cutting needles, it is better to you that place the bevel in parallel to the long axis of the spine, and there is a lower risk of developing PDPH when the patient is placed in lateral decubitus as compared to the sitting position. Whereas using paramedian or median approach, using air or saline to identify the epidural space or the level of epidural insertion does not influence the risk of PDPH. So in short, we need to understand that it is a preventable complication, and its preventability lies mainly in the hands of the practitioners. And it is very important that we try to adapt these best practices into our routine clinical work. Moving on, we go over to the prophylactic strategies to prevent PDPH after an intentional or unintentional dural puncture happens. So, when you are doing an epidural and you accidentally puncture the dura, you have three options. You either abandon the procedure, or you place an intrathecal catheter to the same needle and provide further anesthesia or analgesia, or you resite the epidural at a different site, but there is again a chance of dural puncture. Now, intrathecal catheters are one of the widely investigated interventions, but still, in spite of numerous studies being there is still insufficient evidence to confirm that intrathecal catheters decrease the risk of PDPH or the need for blood patches. So it is recommended that after an accidental dural puncture, intrathecal catheters may be considered to provide anesthesia and analgesia, but we need to consider the potential risks associated with these catheters. Prophylactic blood patch is where you inject blood into the epidural space even before the patient develops a blood PDPH. Now this has two problems. One is that this procedure is associated with variable success, and it's not necessary that every patient who has a dural puncture develops the headache. So the policy of routine prophylactic blood patch exposes a patient to unnecessary potential risks, and it is not recommended as a routine prophylactic measure. Bed rest again improves the symptoms temporarily, but is not effective in preventing the PDPH from developing, and it is not routinely recommended as a prophylactic measure. Any epidural, intrathecal injections or systemic drugs, none of them are recommended as a prophylactic strategies. Moving on, we now go on to the stepwise management of a patient who has been diagnosed with a PDPH. So conservative management is the initial management always, which focuses on symptomatic relief while the dural defect heals spontaneously. Mild to moderate cases resolve within days, and prompt escalation is necessary when the symptoms are severe or persistent. So there are no RCTs examining the effect of bed rest for the purpose of treatment. Temporary relief may be obtained, but these two again is associated with the risk associated with immobilization, and evidence does not support routine use of bed rest as a therapy. Increased oral or IV fluid intake is encouraged because it has the potential to increase CSF reduction. Abdominal binders work by increasing spinal pressure in the spinal canal, but again evidence does not support the routine use of binders for the treatment. Moving on to the pharmacological management. Caffeine is again one of the most commonly prescribed drugs. It is a highly efficient, non-invasive treatment option, and it may be offered in the first 24 hours of symptoms, and the maximum dose of 900 mg per day may be prescribed, but it should be reduced to 200 to 300 mg if the patient is breastfeeding. Or a regular multimodal analgesia with acetaminophen and NSAIDs should be offered to all patients. And short-term use of opioids can be prescribed if the symptoms still don't resolve, but evidence does not support routine use of hydrocortisone, theophylline, gabapentin, etc. Now, several studies have come up even after these guidelines were published, and several drugs are being investigated. And dexmedetomidine is a new player on the ground, and this study as well as this meta-analysis has shown promising results in the ability to reduce the pain scores and as well as a requirement for blood patches. So moving on to the interventional strategies, epidural blood patch is considered to be the gold standard therapeutic option. But on the flip side, 30% of the patients may require a second blood patch because of the persisting symptoms. And serious complications have rarely been described. So there are 14 recommendations in this guideline regarding the blood patches. It is indicated when the blood headache is refractory to conservative therapy and impairs daily activities of life, or when patient has neurological symptoms. Now, if an epidural blood patch is performed within 48 hours of dural puncture, the patient should be warned about the need for a second blood patch because the symptoms might still recur. And strict aseptic precautions should be maintained. When the site of dural puncture is known, epidural blood patch should be performed ideally at or one space below this level. And in case you think that the needle insertion might be difficult for any reason, you should always use radiological guidance. Informed consent for this procedure should include the potential for repeat dural puncture, backache, and neurological complications. And blood should be injected slowly and incrementally. And if patient develops headache or backache, we should stop the injections. Optimal blood volume is not known, and it varies for multiple reasons, and most recommended volume is between 15 to 20 ml. Epidural saline may be of temporary benefit. Fibrin glue is indicated only when the PDPH is refractory to blood patches or when autologous blood cannot be given. So, sphenopalatine ganglion block has several approaches, with the transnasal approach being the most easiest, where a cotton tip dipped in local anesthetic is placed deep into the nasal canal, and it's a minimally invasive, associated with low risk of complications, but it is yet to prove its effectiveness, and at present evidence does not support routine use of this block to treat PDPH. With the greater occipital nerve block, the same thing, the evidence is there for proving its efficacy for PDPH following dural punctures with narrow gauge. So if the PDPH occurs after a narrow gauge insertion, then you can use a greater occipital nerve block. So with that, we complete the treatment of a PDPH. But are we done there? And does the problem resolve in 2 weeks? Apparently no, because this study deals with the long-term psychological and physical outcomes of women after PDPH and shows the numerous complications that the patients may develop. And a chronic headache is one of the most common complications. So this review throws light on the mounting evidence of development of chronic headache in these patients. And this provides important implications for the anesthesiologist in terms of follow-up of these patients, and as well as the importance of including these complications in the informed consent for any subarachnoid or epidural blocks. So the pathophysiology may be the ongoing CSF leak, and imaging in these patients may provide evidence of the source of leak. For example, the CSF fistula or arachnoid blephs, and if identified, a surgical management may be required for these patients. So that brings me to the last part of my talk, the recommendations for follow-up of these patients who develop PDPH. So before discharge, information regarding sequelae should be conveyed with arrangements for appropriate follow-up. The person responsible for the dural puncture should ensure that the primary care physician is informed of the management and the long-term symptoms. And follow-up with patients who experience PDPH should be continued until headache resolves, and urgent neuroimaging and referral should be done if the patient has new neurological symptoms or change in nature of headache. So the key recommendations are to optimize the technique, diagnose clinically and image selectively, start with conservative management and escalate promptly, and individualize care by integrating shared decision-making, patient preferences, and the clinical context. So for the road ahead, the management of PDPH requires a balance between traditional practices and emerging evidences. Procedural improvements have significantly reduced its incidence, but it still remains a reminder of the delicacy of our neuraxial techniques. And existing evidence has several limitations, including small sample sizes and heterogeneity, and we need more extensive, more rigorous trials to determine the efficacy of the treatment strategies. So, and most importantly, greater awareness, adherence to evidence-based recommendations, and patient-centered care is essential to minimize its impact. Thank you all for your patient listening.
Thank you, ma'am, for this practical session.